I'm going to talk to you about the dynamic MPFL reconstruction as a technique that is not that known, but more and more people start using it. These are conflicts of interest that I have, not for this lecture. So if we go and see all the recurrent lateral dislocations of the patella, we see that a dislocation is caused by a pathomorphological joint geometry. And if we go through the literature, we can see there are more than 100 procedures that they are described. As Stenson said in 2015, a patella dislocation is not a coincidence, but it's a mechanical event being a result of a false or a pathological anatomy. Till now, we know lots of procedures, either the ones that change the load direction of the extension mechanism of the patella by forces that actually lateralize the patella, procedures, for example, insole procedure, which is not being used that much anymore. And of course, on the other side, we have the reconstruction of the medial soft tissue structures, the MPFL. So MPFL, as we all know, is the commonly injured ligament, and it's elongated in most cases after patella dislocation or after recurrent lateral patella dislocation. And it's a really, really important tissue for the stability of the patella. If till now, what we've seen are the static MPFL techniques that have been described, with the most common one being the Shuttler technique by using a gracilis tendon as an autograft, and you have two fixation points, one the patella in the one in the femoral fixation, the so-called Shuttler point. What's is exactly, as I'm going to tell you in a bit, the problem in this case. We've seen in this MPFL, in the static MPFL procedures, we've had a good clinical results up to 5 years, but still, post-operatively, we see quite a lot of complications. Most possible complication are the over-medialization of the patella, and of course, the incorrect placement of the graft and the femoral point. And if we see the systematic review that Shaw actually did in 2012, including 25 articles and 629 knees, we saw there was a complication rate of 26.1%. One of these being a patella fracture, limitation of the range of motion, pain, and instability. So that's why in 2007 and then afterwards 2014, first Ostermeyer, then Becher, the one that modified this technique, came up and they said, okay, we have to find something else. And they came up with this dynamic MPFL reconstruction. The indications for it are pretty similar with the ones with the static MPFL reconstruction, but at the same time, you can use it even in young patients, patients that don't have, for example, closure of the epiphyseal plates. Of course, contraindications is a huge valgus deformity, more than 15 degrees TDDG, distance 2 centimeters, an anteversion more than 25, and of course, not having semitendinosus or gracilis tendon or having a neurogenic instability. Before we go on and do this technique, we have to find out, of course, we have to have an MRI in order to evaluate the MPFL and measure the TTDG distance. In case of valgus deformity, we do a full length X-rays in order to measure that. And of course, in anteversion, we do a rotation CT scan in order to maybe proceed and do an osteotomy, derotation osteotomy. And of course, we can use the patella tangential view X-rays to evaluate if we have a patella dysplasia or a trochlea dysplasia. What we actually use as a guide is this table has been described as from the committee of AGA, the German Arthroscopic Society in 2015, what it has to do with the instability of the patella in different degrees of flexion in 30, 60, 90 degrees. So it depends on the degrees. We have to see and actually apply the technique that we have to do. So the technique itself is quite simple. What we do, as you see here, is as we know from the ACL surgery, we just detach the gracilis tendon, or you can even use the semitendinosus tendon, but you just detach the gracilis tendon on the distal attachment. And then what we do on top of it is we have to whip stitch the tendon. In my case, what I do instead of because I want to kind of spare some time, I don't want to lose some time. What I use is this quite good tool that I have there as a so-called speed trap. So you just pull on the sutures, and you have your whip stitch right away, and you just have to remove the end of the tendon, as you see here. So in order, when you pull the tendon into your bone canal afterwards, it can pass through it easier. So afterwards, you do a medial incision, medial to the patella, and you dissect the patella, the first 1/3 of the proximal patella, the medial side, till the bone, in order to find out the attachment of our tendon, of our graft. And afterwards, you have to open up the fibrous membrane. And after doing that, you bring your clamps, as you see here, this overhauled, and you have to do it a couple of times in order to do your tunnel and to have an easy access. And what's really important here is that your clamp here, when you bring your tendon, has to be anterior, as you see here, anterior from the sartorius fascia, because that's the key point of this operation. The sartorius fascia plays a great role here as a hypomycelium that actually helps the tendon have the vector that we need. And in this case, we bring the tendon proximally. On top of that, we kind of release the tendon in order to have kind of to slide a bit better, to have a better access, to have a better pull. Then what we do in the medial third, the medial proximal third of the patella is, as you see here, we bring a guide, as we know from the ACL surgery. We do it transpatulally, and then in order to exclude or to be sure that this guide is not in the joint, we can use our arthroscope and just have a look if it's in the joint. If it's in the joint, you have to reinsert it, of course. After that, we ream 15 to 20 millimeters of depth in the patella, not more than that. And the rimmer is a 4.5 rimmer, as you see here. Then what we do is we need here, you need a passing suture, a shuttle suture, where we bring the sutures of the loaded tendon to the other side. And then after bringing the sutures to the other side, as you see here, we have to pull on these sutures in order to get the tendon in our bone canal that we reamed already. Afterwards, we have to flex the knee in 30 degrees, and we put on the other side on the sutures, and we most of the times it's kind of tricky. We have to help kind of the tendon in order to get it in the hole, as you see here with a kind of a clamp. It's another maybe trick that I might suggest here is to move. You kind of do a circle and on your reamer in order to have the entrance of your hole a bit bigger in order to bring your tendon a bit easier in there. And then you put your guide there, and what we bring is the smallest screw that I've found is a 5 by 12 millimeter screw. It's a Milagro screw, and in 30 degrees of flexion. And by just pressing the patella to the medial side, we fix our tendon in there. On top of it, what I do at the end, you see here how stable the tendon is. What I do at the end is on the other side, I do the so-called safety sutures. And if you want to reinforce your whole construct by closing up your fascia, you can take the tendon on top of it, so you have a kind of the triple enforcement. So the aftercare after the operation is a 2 weeks of a PT control brace in 0, 10, 30 degrees. And then the 3 to 5 weeks, you have 0, 0, 60 degrees, and the following 2 weeks, 90 degrees. The weight bearing of the patient is 4 weeks. We give him a partial weight bearing, and then he can proceed with full weight bearing. The only disadvantage of this procedure is the pain post-operatively because of the tension of the tendon. That's why we use some catheter that our anesthetists actually have to kind of do it on our patients. In conclusion, this technique is really safe. It's an easy technique. We don't have the placement failures on the femur because we don't have any fixation point there. It can be used even in children with open epiphyseal plates. And biomechanically, there is no alteration of the patella kinematic, as Ostermeyer said, and it's not in comparison to insult procedure where we notice an patella tilt or an over-medialization in the static MPFL reconstruction. Thank you very much for your attention.